It's my pleasure to give this talk before you all today. And so this is part of our core lecture series that we like to give on a 2-year cycle. And these are important organisms and important syndromes for us to all know. So I titled this talk, The Spirochetes, Leptospirosis, and Relapsing Fever, but really the spirochetes encompass 4 genera, including Leptospirosis, Borellia, and can anybody name a third? Treponema. And then what's the last one? It's called Brachyspira. It's the etiologic agent of intestinal spirochetosis. So, but today we're going to be focusing on Leptospira and Borrelia specifically. There's been a little change in the nomenclature, particularly for relapsing fever, some new concepts. So we'll make sure we give those. I last gave this talk 2 years ago. So we're going to start out with a case, and this is an actual case that presented to the VA a few years back. Actually, Dr. Pardo and I were involved in this case directly when Dr. Pardo was a fellow. So this was a 64-year-old male in the emergency department who complained of 3 days fever to 101.9, chills, nausea, vomiting, diarrhea, mild headache, generalized malaise, weakness, and low blood pressure, and had just returned from an 11-day Caribbean cruise. The patient reported travel to those destinations listed in the slide: Aruba, Curacao, Bonaire, Jamaica, Dominican Republic, and Costa Rica. How many people have been to any of these destinations? Raise your hand. Okay. Which ones?
Costa Rica.
Costa Rica.
DR. Oh, I haven't.
Okay. Anybody else? The DR? Yeah. Yep. All right. So this gentleman was pretty active despite, being 64 years old. Participated in numerous outdoor activities, including river tubing, zip lining, and snorkeling. He mostly drank bottled water. He avoided street food and denied any animal exposures. So he was seen in the emergency department at our facility, and there he had a very high fever, 104, tachycardia, and refractory hypotension. On physical examination, he was obviously jaundiced. He had scleroicterus, conjunctival suffusion, and some subconjunctival hemorrhages. CBC, as the slide suggests, had several abnormalities of his blood counts, leukopenia, anemia, and thrombocytopenia. On his metabolic panel, he had elevated liver enzymes and marked a total hyperbilirubinemia and direct hyperbilirubinemia. His creatinine had increased to 5-fold above baseline, up to 3.7. Not sure why this is doing that. Oh, it doesn't like it. Okay. So DIC and hemolysis were ruled out, and he had thick and thin smears sent to the lab, and there were no plasmodia seen on peripheral smear, no schistocytes, and no malaria parasites seen on his thick and thin preps. On abdominal imaging with a CT abdomen pelvis, he had hepatomegaly, no signs of obstruction, and no signs of hyperamylasemia or hyperlipasemia. So obviously this is a talk about leptospirosis and relapsing fever. So I know you all are thinking about some things. So, but what would you think about as far as a differential at this point? Anybody?
This you think like this results malaria.
So malaria potentially. How about some other tropical infections, maybe arthropod-related infections because of the association with the Caribbean. Dengue fever, chikungunya. And so we're thinking about arthropod-borne infections and potentially one of the syndromes that we're talking about, right? So the patient was admitted to the hospital. Got started empirically on broad-spectrum antibiotics, vancomycin and doxycycline too, because we were thinking about obviously arthropod-borne syndromes. What are some arthropod-borne syndromes that might respond to doxycycline? So we're thinking about rickettsial diseases, right? Potentially Leptospira. So he was broadly covered. This is a picture of him on the upper right. He was sent to the ICU, and he began to develop respiratory failure and actually had to be intubated. He was broadly cultured, and cultures were negative. And eventually, his antibiotic therapy was consolidated to doxycycline and ceftriaxone. And he had a very tenuous course. There was some really dicey moments there when we thought he wasn't going to make it. I mean, he's over 60, and he has a really diffuse septicemia, septic shock, and so forth, and very tenuous. But unfortunately, he did eventually recover from this syndrome. So does this sound like it could be any particular syndrome? Anybody have any other thoughts? No? Well, let's see what happened. So, infectious disease workup was initiated, and these are some of the results. Malaria smear showed no parasites, but I mentioned that earlier. He had dengue IgG and IgM antibodies, also negative. Dengue PCR was not detected. Chikungunya, IgG and IgM antibodies were negative. PCR of chikungunya not detected. Zika, IgG and IgM antibodies. Zika virus was more. There was more awareness and more cases back when this case reported. That was also negative, and a Zika PCR also not detected. So there's a lot of arthropod-borne infections there that we have set by the wayside. And so let's say we're suspecting leptospirosis. How would you diagnose leptospirosis? What would you send off? So you might think about serology, PCR, culture. What's everybody thinking about here? PCR, good choice. Anybody send serology, Leptospira, IgG and IgM? No? Well, we're going to cover this. So, but let's see what we sent. So we sent a Leptospira IgM antibody. That was to a commercial lab, and that was initially negative. So some days later, a Leptospira urine PCR came back, and that was detected. And then because of the initial Leptospira IgM antibody being negative, we sent a Leptospira MAT antibody, microscopic agglutination test antibody, to the CDC, and that was positive. And this is the report that we got back using the old style Serovar nomenclature, and it came back positive for Leptospira interrogans, canicola rubush, with a titer of 3,200. So this was a case of leptospirosis. So the diagnosis was Weil's disease, and Weil's disease denotes the form of leptospirosis that's associated with sepsis, renal failure, liver failure, and so forth. So this was acute leptospirosis. And what was his risk factor? Well, his Caribbean cruise included a stop in Ocho Rios, Jamaica. And how many people have been to Jamaica? Anybody? Nobody? So Ocho Rios is on the island of Jamaica. It's kind of like at the 2 o'clock position. It's a popular cruise port. And the patient was getting kind of bored on the ship, so he de-cruised onto the port, and he saw a kiosk that said White River tubing, and he got interested, and he ended up signing up for that. And as it turns out, his visit to Jamaica occurred during the rainy season. So he opted for the White River tubing, and during that time, he believes that he immersed his face in the White River, whereas his wife did not. And so the risk factor was thought to be that White River tubing excursion that he took. And during rainy season, a lot of times rain can wash effluviums from the surrounding land into a river and increase the likelihood of exposure. So my Spanish is not very good, but I know that Ocho Rios means 8 rivers, right? So there's a lot of rivers in Ocho Rios, and the White River is one that has a very popular tubing activity. And this is from the tour site. It's the White River there in Ocho Rios, Jamaica. So you may ask yourself, leptospirosis, it's not really something I need to worry about unless I'm on a Caribbean cruise or I go to one of the major places where leptospirosis is thought to occur. What's a major U.S. state where leptospirosis occurs? Anybody want to throw up your hand?
Florida.
I'm guessing Florida.
Well, Florida might be a good choice, but it's not one of the one I'm thinking of. Hawaii, right? So Hawaii is associated with a lot of leptospirosis. And this is the ad for tubing in Ocho Rios. So you may want to skip this on your Jamaican trip. I'm just saying. But actually, believe it or not, I found this in Clinical Infectious Diseases from 2010, and it's an outbreak of leptospirosis among adventure race participants in the Hillsborough River State Park, where there were approximately 40 cases out of 200 in individuals who were canoeing, portaging their buddy canoe. What is portaging? Does anybody know? What is it?
It's like when you put your canoe in your head and you walk between like land bridges, like that connect lakes or rivers.
So maybe there's water in the canoe. You stick it on your head upside down. The water comes down your face, and you get exposure. And they were also swimming in the Hillsborough River. This is an actual picture of somebody swimming in the Hillsborough River. How many people have gone to Hillsborough River State Park? So, yeah, be careful. Alligators and lepto. So, yeah, be careful. I'm just saying. So, there's this can occur in Florida, and it's quite widespread actually. So let's talk about the basics of leptospirosis. It's caused by pathogenic spirochetes in the genus Leptospira. We talked about it's one of the 4 genera of spirochetes. It used to be classified under this serovar classification system of 300 or more serovars, 10 pathogenic species. But with genetic sequencing, it's actually been reclassified, and there's a new phylogeny, 64 species, 2 clades, and 4 subclades, typically associated with tropical areas, which include Florida. And there are actually cases reported in Florida every year. It can be difficult to diagnose, and that's one of the reasons why it's underreported. And but there's thought to be about 1 million cases globally, 60,000 deaths. So it does cause significant morbidity. And we'll talk about the life cycle and how humans fit in the whole life cycle. And the gentleman in this room, you are predominantly overweighted in terms of gender distribution. I think it's because of lifestyle and activities of male persons versus female persons. Maybe that's changing, but predominantly men tend to be affected more than women. So in the U.S., most cases are in Hawaii and Puerto Rico, but cases an average of 5 to 7 cases in Florida occur every year. And Hillsborough County, up to the pandemic, had been having 1 to 2 cases per year. But for some strange reason, there haven't been any cases reported in Hillsborough County up to 2023 since 2019. And that same is true for Pinellas County. However, outbreaks can occur after heavy rainfall or flooding. So what's one thing that we've had in our area in the last 2 months?
Hurricanes.
Heavy rainfall and flooding, right? So there's no doubt our risk factors are increased for leptospirosis in our area with people wading in floodwaters and with heavy rains and all the water that we've had. So my point is that even though we haven't had any cases since 2019 in Hillsborough County, we're highly at risk. And as many of you were discussing before the talk, our hurricane season is not over. We could be facing something around the middle of next week. So start watching those news forecasts and formulate your plan C, since your plan A and plan B, and in some cases your plan C, maybe your plan D, because we've actually had 3 storms kind of come by in close proximity to us. So the most important reservoir for leptospirosis are rodents. And so rodents are a main vector for the organism to enter into bodies of water or flood water through rodent urine. But other mammals like cattle, swine, dogs, horses, and sheep, and even goats can also be infected. Cats are less likely to be infected with leptospirosis, so you don't see cats on this list. And after a rodent acquires the infection in infancy, it can continue to shed the organism throughout life. And the organisms may remain active for a long period of time, for days to months. So this doesn't really go away in the environment after it's introduced. So here's the transmission cycle, and you can see it alternates between rodent carriers and mammalian reservoirs. And so human infection is really incidental, right? Humans are not primary hosts. There's a difference between that and the other syndrome that we'll talk about. And so risk factors can include contact with animals, animal urine. So you could be a veterinarian, for example, and be at risk. But how about butchers or abattoir workers, hunters, farmers? So occupational risk factors, but also recreational risk factors, water sports, swimming in the Hillsborough River State Park, fishing, rice farming, those sorts of things. So most exposure is environmental, and the organism enters through broken skin, mucous membranes, conjunctivae. So if you're swimming in a Leptospira infested body of water and you splash your mucous membranes, or you have a cut in your skin, or you ingest water where you have breaks in the skin in your mouth, for example, you can acquire leptospirosis. Rarely you can acquire it by ingestion of contaminated food. I listed sexual intercourse here. It's really not all that common. However, IV drug abuse is a rare cause. This is something you want to think about if you're whitewater rafting or participating in adventurous water sports. So these are risk factors for leptospirosis. Triathletes. How many people have done a triathlon? Anybody? Okay. So, yep. Kayakers, farmers and ranchers, military personnel. If you're conducting military activities in aquatic environments. There are a lot of sewer workers after the recent hurricanes going down into the sewers to kind of clean out debris. That's a risk factor. Also, laboratory workers, returning travelers like the index case that we talked about at the beginning of this talk. And then in endemic areas, and this is very unfortunate, if you live in an area with regular cases of leptospirosis and you happen to be in an urban area with poor sanitation, you can be exposed. So these underdeveloped countries have a continuing risk factor.
This is really only like fresh water though, right?
It's not associated with salt water, so it's usually fresh sources of water. Exactly. So let's talk a little bit about the microbiology of these organisms. So these are highly motile aerobic spirochetes that are kind of shaped in sort of a question mark without the dot. So if you think about Leptospira, think about a question mark type of organism. They don't stain well. They're best visualized by dark field microscopy, but try to find a dark field microscope these days. I don't even know if we have one at the health department anymore. Dr. Tony has lamented about this. Dr. Tony, if you were on the call today. However, silver stain or fluorescent microscopy can pick them up. And so you can isolate the organism from culture for blood, urine, and CSF. But there are certain time frames. You're more likely to isolate it from blood in the first week, from urine during the second week. It does require specialized media, which I've listed here. And you do want to notify the lab if you're suspecting Leptospira because of the danger to laboratory personnel. So when you think about the clinical manifestations of leptospirosis, you think about two phases, the acute phase and the immune phase. So the acute phase is usually has the more acute kind of septic-like effects, and the immune phase has more of the immunologic effects, where the syndrome occurs due to immune system activation, not so much because of a lot of bacteremia with this organism. Incubation period can be pretty prolonged, from anywhere from 2 to 30 days. 5 to 14 days is typical, and most people present with a febrile syndrome, fever, myalgias, rigors, and headache, which is why it's easy to understand that you have a broad differential, which includes arthropod-borne infections, right? Like dengue fever, for example. So some typical symptoms of the acute phase, the conjunctival suffusion, the jaundice and photophobia that we saw with the patient that presented to us. There may be initially a dry, non-productive cough, abdominal pain and vomiting, diarrhea, muscle pain, and rarely a skin rash. And then that can transition into the immune phase, where you get those immune system complications like meningitis, lung hemorrhage, myocarditis can occur. You can have renal failure and other similar complications. The meningitis obviously presents as kind of an aseptic meningitis picture. And so I have a little pictograph there from the Cleveland Clinic showing the symptoms of leptospirosis. Some other details: nausea, vomiting, and diarrhea occur quite commonly, about 50% of the time. You can have arthralgias, bone pain, pharyngitis, and aseptic meningitis I spoke about before. So we mentioned that Weil's disease is leptospirosis complicated by jaundice and renal failure. A severe pulmonary disease can progress to ARDS, can be quite profound. You can have more multi-organ failure involving the liver, the kidneys, and effects of digital ischemia, myocarditis. So this can affect many vital organ systems and can cause serious disease and even death. What are some diagnostic findings? You don't often see much of a leukocytosis. Typically, it's under 10,000. What you do see is thrombocytopenia and pancytopenia. Severe leptospirosis can present with hyponatremia. That's a good diagnostic sign to be on the lookout for. As with our patient, liver hepatitis, transaminitis, and jaundice are commonly seen. So, you know, you can figure out, put together a mental picture of somebody who presents with sepsis, fever under the right exposure circumstances, renal failure, liver failure, even respiratory failure. You know, this leptospirosis needs to be on the back of your mind as you consider someone who presents like this. On the urine, you see proteinuria, pyuria, CSF typically presents as a lymphocytic, predominantly lymphocytic pleocytosis with elevated protein. The glucose, however, is normal or slightly elevated, and you may see some small inflammatory changes initially on the chest X-ray, progressing to ARDS and respiratory failure. So I put together this as the differential diagnosis list, and we already talked about some of these like malaria, dengue fever, other arthropod-borne diseases. Now, when you look at these, not all of them present in the same region. So obviously, if you're in the Caribbean and somebody has a febrile illness, you're going to think about dengue. But let's say you're in the American Southwest and somebody presents with a febrile illness. Maybe they were in a wilderness area with a stream, and it was very rainy, and they drank water from a stream, and they got a febrile illness. In the West, you'd be thinking more about hantavirus, right, as a potential differential diagnosis. And then acute viral hepatitis A, that's something you should screen for because that can present with fulminant symptoms and liver failure. So think about these in the differential diagnosis. So the key to diagnosing leptospirosis is a strong clinical suspicion, right? So the purpose of this talk is to kind of bring this in everybody's mind. And as I said earlier, the organism can be cultured, usually best cultured during the first week from blood and after the first week from urine. CSF can also be positive, but the thing about CSF is by the time you get the meningitis, a lot of times those are the immune system manifestations. And so there aren't as many organisms in the CSF during that meningitis phase. So your CSF may not be positive when you perceive that meningitis may be present. Leptospira DNA, PCR-based tests are really important. They are very rapid. They are sensitive and specific. And the problem with serology is initially serology may be negative in the acute phase. That's what happened with us in this patient. We ordered serology from a commercial lab initially. It was negative. And then, so when you're thinking about serology, acute and convalescent sera is more helpful because your initial serology may be negative, but when you check it a week or 2 weeks later, it may be positive or the titer can be higher. And MAT testing, the microscopic agglutination test, is offered through the CDC, and it can give you Serovar. I'm not sure if they publish the results differently now with the new classification system, but back at the time we got MAT testing, we were provided with the Serovar. So, and a lot of these commercial IgM tests aren't all, they don't. Leptospira is common, but they don't get enough frequency of the test. Really, I think sometimes their test quality may not be ideal, and so a negative IgM test doesn't necessarily rule it out, and a positive IgM test isn't always specific enough for Leptospira. So you really want to order both if possible. Get the PCR and the serology as well to support your diagnosis.
Dr. PCR testing that you sent at FDA, what would
As I recall, it was well within a week. It might have been five or 6 days. It was sent to Quest, and so there was some turnaround.
that's the test we should be sending now something.
I would send the PCR from blood, and it's more likely to be positive from urine in the second week. So yes, and then also you can order serology as well.
Okay.
And you may culture it out of blood or urine, depending on the timing.
But for this patient that you presented, it was only the urine PCR that was positive?
The urine PCR was positive, and then also we eventually got the microscopic agglutination test.
Oh, okay, and
Yeah.
that was positive.
And that was positive from the CDC. So let's talk a little bit about treatment. And so the thing about treatment is it varies widely because many patients who acquire leptospirosis are either asymptomatic or they have mild symptoms. They may not need any treatment at all. And then that can range all the way to somebody with severe fulminant disease with septic shock and multi-system organ failure. So a lot of the treatment for those very severe cases is supportive. For renal failure, obviously, dialysis, managing their respiratory failure, giving circulatory support and blood products. That's a major part of the treatment. And I read some evidence that it's not even sure that for these severe cases that antibiotics really contribute that much to the whole syndrome, because remember, a lot of this is immunologic and you're just managing their immunologic phenomenon. But still, I think all of us would give antibiotics without question. And speaking of antibiotics, basically remember, these are leptospirs, just like syphilis. So you'd think they respond to beta-lactams, right? So indeed they do. And the drug of choice typically for moderate to severe leptospirosis is aqueous penicillin G. And so if you have milder disease, oral amoxicillin, or in non-US countries, oral ampicillin can be given. And if you have somebody who has a beta-lactam allergy, then doxycycline is an alternative. Ceftriaxone, also an alternative, 1 to 2 grams IV daily for 7 days. And so treatment is typically for 5 to 7 days with your antibiotics. And to those of you listening online, I think I do hear somebody's mic open. So if you could check your mic and make sure that your mic is not on, and that we would appreciate that. So what about prevention for leptospirosis? Well, there are human vaccines available, but they're serovar specific, so they're really not that helpful because you don't know what serovar you're going to come across. Really, the main way of preventing this is avoiding sources of infection. There are animal vaccines available, which can help reduce leptospirosis in herds, for example. And if you have somebody who is at the highest risk of infection, you can see that at the bottom there. You can actually prophylax with doxycycline, 200 milligrams orally per week. So prophylaxis is possible. I don't know if you all decide to go White River tubing in Ocho Rios, take your doxy beforehand. All right, so any other questions about leptospirosis before we launch into our next topic? Yes.
Hi, this is Jamie. Go ahead. I'll go when you call on me. Sorry.
Oh, 1 second, Dr. Morano. David had a question here in the room, and then we'll get to you.
So
Yes.
you mentioned the PCR testing. What is the role of cell-free DNA testing like Carius?
Well, I think that the Carius technology is definitely an emerging technology that people are trying to get comfortable about when it's appropriate to order. What I like to say is we've been diagnosing leptospirosis for many years without that technology. And so I think these specific tests would be the primary way of diagnosing: PCR, serology, and potentially culture. But if you have a patient who's kind of a conundrum and you haven't figured it out, then and you have the Carius test available, that certainly is an option, and it can help. Of course, Carius test has its strengths and pitfalls. We don't have it available at my institution, but it is available at Tampa General and at Moffitt, and I think it has cracks and cases. So good question. Yes, Dr. Morano, what's your question?
Hello, good morning. Everybody hear me okay? First of all, excellent presentation, Dr. Oehler, fantastic. I just wanted to maybe at 2 points and a comment, phenomenal. I actually had the opportunity to see this patient on weekend call, and I totally agree with you, and kudos to the team. It did take, a lot of steps to get this diagnosis. And I just wanted to say, congratulations on getting to the cause. And he was incredibly sick, so well done in getting him to full recovery. And I think some of the interesting points post-COVID, just putting my, old Department of Health hat on, I think sometimes people may not know the diagnosis in the community, right? They may not report it. They may not be able to send out the lab. So I agree with you. It's so important to keep this in the differential as, fellows graduate and we all, go to different practices. So important. I put something interesting in the chat just for further reading. I didn't know this, but there was a case from Miami actually in a homeless individual. So definitely transmission in the United States, not only from recreation, but it looks like, from just rat exposure, it sounds like, and also farmers, which I didn't know in Florida. So you're absolutely right. It is in Florida and we definitely have to keep it in differential. So no, thanks. Great presentation.
Thank you, Dr. Morano. Yeah, I mean, talking about the rodent link, those of you who've been paying attention to some of the hurricane coverage over the last few weeks, there's a bunch of people with all their belongings and parts of their wallboard and what just piled in piles above their home. And then with extra rain, you get rodents coming into those piles of garbage, and more rodents can be associated with a greater risk of leptospirosis. So there are all these risk factors for Leptospira in Florida right now. And so hopefully we won't see too many cases, but I wouldn't be surprised if we did not. Let's move on to our next syndrome that we're going to talk about, our second spirochete of the morning. So I'm going to start this also with a case. This is not a case that I managed. I took this from a case report, and it was a 37-year-old male who was seen in the emergency department in central Utah in the spring with recurrent fevers, headaches, myalgias, and chills. 3 weeks earlier, had traveled to Jordan and visited archaeologic sites. I'm not sure if this is the specific site he visited, but it was very lovely. Little horse there and a mule. Probably rode there on the mule. So he developed fever and sought medical care in Jordan and was treated with azithromycin for 3 days. Since returning from his trip, he had basically not had any significant additional exposures or animals or insect bites. So, thinking about what this could be, obviously the idea could it be Lyme disease or a tick-borne syndrome. So Lyme disease serology was sent, and the initial screening ELISA was positive, but the Western blot was negative. Thick and thin smears were collected and were negative for parasites. However, providers were later contacted and informed that spirochetes were detected. So you guys can see the spirochetes, right? Right here, obviously. There's another one here. And so what are we thinking about here? What is the species name of this spirochete? So it's not Leptospira, but it's what? Starts with a B?
Borrelia.
Borrelia, very good. So the finding was strongly suspicious for relapsing fever, and the organism was ultimately identified as Borrelia persica. This is a endemic species to Jordan in the Middle East. So patient received treatment with oral doxycycline, vitamin D, as I like to call it. Sure you have enough vitamin D at home. No, that's not an endorsement. And was lost to follow-up. So the exposure risk factor was felt to be exposure to ticks in Jordan. So relapsing fever, this is the second spirochete we're going to talk about. And so the family Borreliaceae includes two genuses, Borrelia and Borrelia. So Borrelia are the agents of Lyme disease, and Borrelia includes relapsing fever, avian spirochetosis, and bovine borreliosis. So we're going to be talking about Borrelia today. So relapsing fever also is spread by arthropods, but what's interesting is by two different arthropods specifically. You have louse-borne disease, which I will refer to as LBRF today, and then tick-borne disease, which I will refer to as either tick-borne relapsing fever or soft tick relapsing fever. The reason why there's this additional designation is soft tick relapsing fever. There's actually a hard tick relapsing fever, which we'll talk about in a second, but I'm going to focus on the soft tick, the traditional form. So basically, the reservoir for louse-borne relapsing fever is people. So this is different than leptospirosis. It doesn't really have a human reservoir. And the reservoir for soft tick relapsing fever are rodents and, of course, soft ticks. So there are two different types of relapsing fever. We talk about endemic relapsing fever and epidemic relapsing fever. So let's talk about the endemic version or the soft tick version, right? This occurs in the US and many international destinations. And there are two main species of Borrelia that produce relapsing fever in the US, namely Borrelia hermsii and Borrelia turicate, turicate in the southwest and south central US. I want to make sure I pronounce that correctly. And the vector is this soft-shell tick called Ornithodoros species. Now, the difference with louse-borne relapsing fever is it's called epidemic relapsing fever, mainly because it occurs in areas of great upheaval or social unrest or famine or areas where people congregate together under unfortunate circumstances, and the vector can be spread between people. So this is caused by one species of Borrelia, Borrelia recurrentis. So if you're in a board type situation and they mention Borrelia recurrentis, you want to associate that with louse-borne disease. And of course, there are many species of Borrelia that cause endemic relapsing fever, the soft tick variety. So just one for louse-borne, but many for soft tick-borne. So for tick-borne or soft tick relapsing fever, the geographic distribution of the disease will vary, of course, and the arthropod vector and the Borrelia species varies. So if you're in sub-Saharan Africa, Borrelia daytonii is a big Borrelia species, and the Ornithodoros mubata is the arthropod vector. But if you're in Central and Northern South America, then Borrelia venezuelensis and Ornithodoros rudis are the Borrelia species and arthropod vector specifically. Now, what about hard tick relapsing fever? Well, that's the term that's given to Borrelia miyamotoi. So Borrelia miyamotoi causes a febrile illness. We've all heard about it. And the difference is its vector is the hard tick ixodes species, right? And then for Borrelia lonestarii, that's been associated with this southern tick-associated rash illness, and that's transmitted by Amblyomma americanum and the Lone Star tick, the hard tick. So both of these are associated with febrile syndromes that are where the vector is a hard tick, not a soft tick. And so they're kind of in a separate category, but I'm going to focus on the soft tick relapsing fever. So this is a world map which links particular species of Borrelia with geographic regions. And one thing you'll notice from this is there is no relapsing fever in Australia or Antarctica. And certainly a lot of South America doesn't have relapsing fever, and large portions of Africa. So for the most part, this tends to be predominantly a disease of the Northern Hemisphere compared to the Southern Hemisphere. So if you're traveling to Australia, rest easy. You can die in many different ways, but not from this disease. So these are the vectors of epidemic relapsing fever, or the vector specifically, forgive me. And the human body louse I've placed in the center of these different lice, just to show you the differences. Again, the human body louse does have a similarity to the head louse, and obviously not really associated with the crab louse. And so typically the human body louse fills its abdomen, the abdomen gets engorged with blood. And so a lot of the transmission that occurs with the human body louse occurs when the when the patient, the victim, kind of squeezes the body louse to kill it and squirts that blood out of the abdomen. I know that's kind of gross, but I read that, I thought it was interesting. So in addition to causing epidemic relapsing fever, of course, the human body louse can also spread other similar illnesses like typhus and trench fever. So there are multiple potential infectious agents you want to think about in somebody who has risk factors for being contaminated with the human body louse. And typically, these human body lice are treated by dry cleaning clothing and sheets and relieving crowded living conditions. So there are some important distinctions between tick-borne and louse-borne disease. And typically, tick-borne relapsing fever can have multiple relapsing fever episodes, multiple febrile episodes, whereas louse-borne disease, typically you have a major crisis type syndrome, and then you may have a second, much milder syndrome, and then that's it. So tick-borne disease, multiple febrile episodes, louse-borne disease, usually 1 to 2. Louse-borne relapsing fever tends to occur for a longer period, up to 10 days, whereas tick-borne disease, under a week. And for tick-borne disease, usually require a prolonged antibiotic treatment course. Louse-borne disease usually use single-dose therapy. So that can be a lot more convenient for louse-borne disease than tick-borne disease. Neurologic complications tend to occur more commonly with tick-borne disease, and hemorrhagic bleeding complications tend to be rare, whereas neurologic complications are rare with louse-borne disease, and hemorrhagic complications like subconjunctival hemorrhages and epistaxis tend to occur more with louse-borne disease. Both forms can have the Jerisch-Herxheimer reaction when you give therapy. Remember, these are spirochetes, but it's more common with louse-borne disease. And the case fatality ratio tends to be significant with both, although it can be higher with louse-borne disease. And so perinatal fatalities typically occur postpartum with newborns with tick-borne disease. With louse-borne disease, it's prepartum, affecting the fetus. So I'm just elaborating here a little more on the clinical manifestations. Incubation period, 3 to 12 days. Fever, and then resolution, and then recurrent fever. This is one of those syndromes where the name helps you remember what's going on. It's a relapsing fever, right? It'd be nice if, if dengue fever was called, I get a bunch of aches and I get fever, and then I get a rash. But no, it's called dengue fever. But this is called basically what it does. The fever intervals can last 4 to 14 days. As I said, the frequency of recurrences varies whether tick-borne or louse-borne disease. These are some other clinical manifestations. This can be a very symptomatic disease with headaches, myalgias, rigors, abdominal pain. Remember, neurologic complications are more common in tick-borne disease, delirium, coma, even aseptic meningitis. You can get myocarditis. You can get respiratory symptoms that can progress to ARDS, hematologic manifestations, hepatitis, liver failure, and the pregnancy impacts are shown there. What are the laboratory findings? Mild to moderate normocytic anemia. You don't get much of a leukocytosis. You do get these blood disorders like thrombocytopenia. Also hepatitis, your acute phase reactants can be elevated. And if you do get a aseptic meningitis, you have a mononuclear pleocytosis and elevated CSF protein with normal CSF glucose, similar to leptospirosis. So when do you want to suspect relapsing fever? Obviously, if somebody has recurrent febrile syndrome, especially with a crisis phenomenon, they talk about the crisis phenomenon with these individuals. They get a high fever, they get shaking chills, they get quite sick and ill appearing, and then in a kind of a crisis phase, and then all of a sudden it abates, and they get somewhat hypotensive, and then that recurs, particularly in tick-borne disease, several days later. You also want to suspect that when they have risk factors for exposure to soft-shell ticks or body lice in endemic areas. So think about where those endemic areas are. So how do you diagnose relapsing fever? Well, perhaps the most practical way is with thick and thin blood smears looking for the spirochetes. The best time to obtain your thick and thin smears are usually between the onset of the fever and the end of the crisis phase. You can use thick and thin smears in conjunction with immunofluorescent stains. The tissue stains are shown there. PCR usually is kind of second line because it's usually much more practical to image these organisms with direct visualization. But if there's some question, there are PCR tests available. Other modalities like cultures, serology, less helpful. We'll talk about some of the other diagnostic details here. So again, PCR, at least when this article was published, was largely restricted to research institutions. I haven't checked the Quest test directory to see if they have a PCR for these Borrelia. Culture, again, largely restricted to research institutions because it's time and resource demanding. Animal inoculation was something I found that was kind of interesting. It allows for enhanced sensitivity in cases where you can't directly visualize the organisms, and it can allow you to differentiate between tick-borne and louse-borne disease, but it's very demanding and it's more of a historical research method. And serology is really restricted to epidemiological studies. So I listed the differential diagnosis here you may want to think about, and wherever I have an asterisk, those are syndromes that are transmitted by ticks. So think about these in the differential, obviously based upon the region where you're suspecting the exposure occurred. Treatment, we talked about before. If you have soft tick disease or tick-borne disease, IV therapy is initially preferred. Then you can switch them to oral therapy. Again, this is a spirochete, so Borrelia are penicillin and ceftriaxone susceptible. Tetracyclines like doxy and our alternatives, macrolides, are useful in cases with pregnant women. And treatment duration for soft tick disease can be up to 10 days. Single dose therapy for louse-borne disease. And you want to watch for a Jared Herxheimer reaction. So this is hard to read, but it's from Up to Date. And you can see the main regimens for patients based upon whether they have CNS disease manifestations. So I won't go over that in detail due to time. Louse-borne disease, single dose therapy is shown here. And typically, you think about the administration of single dose oral doxycycline as a dose. For parenteral therapy, procaine penicillin, 600,000 units times 1 is often given. And it's a lot easier to treat when it's a single dose. These are the mortality rates, and you can see for tick-borne disease, they can be up to 70% untreated. So it's important to treat these individuals with antibiotics as soon as you can because their prognosis improves markedly with treatment. And prevention, obviously you want to avoid the vector. It's unlikely that a vaccine is going to be developed. And the post-exposure prophylaxis is slightly different for relapsing fever compared to leptospirosis. It also involves doxycycline, but it's associated with the exposure, and it's usually a 5-day course of doxycycline as shown here. So in summary, let's differentiate these two before we finish up, and I apologize for running slightly over. Leptospirosis, again, widespread zoonotic infection spread by rodents and other mammals. Human infection produces this biphasic illness with the bacteremic phase and the immunologic phase. can produce potentially lethal systemic symptoms. Weil's disease is the fulminant manifestation with liver and renal failure. Diagnosis by serology and PCR. We said PCR is very important. And you treat with antibacterials for up to 7 days. And supportive care is very important as well to manage all these complications of the immune phase. Relapsing fever caused by Borrelia. Main differentiator is the soft shell tick, which is endemic, and the louse-borne disease, which is epidemic. Fever is associated with a crisis that then abates and may recur over and over again with soft shell disease or tick-borne disease. Diagnosis with blood smears predominantly, but PCR is also available. And you treat the soft tick relapsing fever for 7 to 14 days and single dose therapy with louse-borne disease. So does anybody have any questions?